Yes.
So thank you very much, Professor Miran, for supporting this endeavor to augment our knowledge of the endocrinology of bone. So this is part 11, and hopefully you've all watched the previous 10 parts, and they're all available on Professor Miran's websites as well, freely available. So let me just see. So we've done all these topics in red here, and I thought today we could cover these topics here in purple. So how important are vertebral fractures? When should we give zoledronate post-fracture? And how long do the benefits of zoledronate last? Okay, so let's start with the vertebral fractures. So, you know, you've got your vertebral column, you've got your 7 cervical vertebrae, your 12 thoracics, 5 lumbars, and then you've got your sacrals and coccygeal vertebra, okay? And the vertebrae take a lot of weight, okay? They support 80% of the body's weight. So they are susceptible to osteoporotic fracture. So let's go to the first question. And if I bring this across, so that's the code. And hopefully, oh no, is the code different? Okay, the code has changed for some reason to when I made that slide. So this is the code 94536958. 94536958. Okay, on menti.com. So what
I'll put that in the chat, okay? I'll put that in the chat so that people can see it just in case.
Okay, thank you. So what percentage of vertebral fractures are asymptomatic? Is it 15%, 33%, 66%, or 85%?
Just give us a chance to join.
Sorry?
Just give us a chance. It takes a little longer
Okay,
for the first question.
Yeah. So these are essentially, you know, what percentage of vertebral fractures are found incidentally, for example, on when patients have a CT angio, for example, or CT chest or CT abdomen, and they never have noticed any previous pain. So what percentage of vertebral fractures are asymptomatic? Okay, so let's have a look at what you thought. So 66% is the winning answer, and is correct, based on the literature. So let's then, oh, now I've closed Mentimeter. Oh dear, 1 second. We've got one more question. I'll just try and get that back quickly.
So 2/3, you're saying 2/3 of the people who have a vertebral fracture don't know, no pain even.
Correct, yes.
Okay.
So present, and here is the next question.
We can't see it yet.
I'm trying to fiddle it between here. Okay, here we are. So if you have a vertebral fracture, okay, you've had a vertebral fracture, how much higher is your risk of a subsequent vertebral fracture? So if you've had one, what's your risk of another? It goes up by 1.5 times, 2 times, 2.5 times, or 5 times. So 1.5, 2, 2.5, or 5. Okay. So 5, and 5 is in fact correct. Okay, so a dramatically increased risk of further vertebral fractures if you've had one. Okay, so definitely worth us taking vertebral fractures seriously, even when the majority of them are incidentally found. Okay, so if we continue here, so the epidemiology, so the prevalence is approximately 10% in women in their 50s, 60s, so just post-menopause. It's still 10%, which is quite a high amount. It creeps up to about 30% when women are in their 80s. It's the most common complication of osteoporosis, but as we've just seen, 2/3 are asymptomatic and so frequently found incidentally. Okay. More than 1/3 of postmenopausal vertebral fractures will actually occur in women who are not osteoporotic, i.e. they will be osteopenia. So this is the importance, which I've stressed before, of taking osteopenia seriously, especially when they're additive risks. And that's where you use FRAX. So for your osteopenic patients, you put them into FRAX because with the addition of other clinical risk factors, it can dramatically increase their fracture risk. often beyond someone who has osteoporosis, but no additional risk factors. So your differentials, depending on how it presents for the vertebral fracture, are musculoskeletal pain, arthritis, spinal stenosis, spondylolisthesis, so that's the vertebrae slipping over each other, metastatic disease, osteomalacia, neoplasms, hematological diseases, osteomyelitis, and trauma. Okay. So the importance to the patient, well, there's a 5 times increased risk of subsequent vertebral fracture, as we've just discussed, and there's also a vastly increased risk of fracture anywhere else. Okay. Remember, for each 1 standard deviation that you drop someone's T-score, the risk of major osteoporotic fractures approximately doubles. Okay. So patients report to lower quality of life 1 to 2 years post-fracture. That's pretty self-explanatory, especially if it's painful. And there's a 15% higher age-adjusted mortality compared to no fracture. And then when you look at the importance to the economy, you can see the US spends over 13 billion pounds, and this is in 2001, so it would have gone up from then, on vertebral fracture management. And in the UK, a patient who's had a vertebral fracture, a painful vertebral fracture, will require GP services 4 times more than the general population in that first year post-fracture. So the diagnosis, it may just be incidental, as we discussed, on reconstructions on a CT done for other purposes, typically. But frequently, it's also sudden onset pain, worse on moving. The pain can be improved on lying down. And it's actually quite rare to get neurological symptoms. You really need some sort of retropulsion of one of the fragments through the cord to get those sort of symptoms. You should always be suspicious in a patient who's lost more than 4 centimeters in height from their youth. Okay, it's normal to lose a few centimeters due to disc dehydration, but typically in the clinic we say if you've lost 4 or more centimeters, we do thoracolumbar imaging. Okay, the fractures are usually mid-thoracic and below. Okay, so we don't typically, well, I've never seen a cervical osteoporotic fracture. Okay, so that would be not that they're not more likely to break the cervical vertebra if you have osteoporosis, but it's the actual way the forces work. It's going to be further down in the body where there's more weight going through, and it's sort of typically in the sort of lower thoracic, upper, and throughout the lumbar. Okay, so lateral X-rays are the first steps. You can do thoracolumbar X-rays, and then you can do CTs and MRIs, which are useful for examining the sort of retropulsion, the extension of the fracture, and involvement of the cord. Okay. Typically, the spinal surgeon, so in Imperial, we have an orthopedic spinal team who are on call 24/7. They can review these vertebral fractures if they want to do any surgical management. And they typically will order an MR, because here you can see the edema in the vertebral fracture, which suggests recency. Okay, normally within the last few months, there's still edema. And normally, the weak evidence that there is for kyphoplasties and vertebroplasties suggests that there's more beneficial in the early stages, so when this edema is present still. And this is a good way to find out if a fracture is new or old, when you find an incidental fracture.
And then there's a comment from Ashjid about even with osteopenic vertebral fractures, because the FRAX calculator relies heavily on femoral neck BMD, there's often no change in treatment.
Yes, okay, yes, this is a big problem with FRAX. So FRAX uses femoral neck BMD, as we know, and it uses femoral neck BMD because that's the most closely correlated and the most accurate in terms of fracture risk determination. However, you will have all seen a lot of patients where their lumbar spine BMD is much worse than their femoral neck BMD. And in these cases, you can apply a crude correction, which has been sort of published in the literature, which is basically to times the fracture risk that comes out of FRAX by 10% for each 1 standard deviation worse that the spine is than the femoral neck. So for example, the femoral neck was -1 and the spine was -4, that's 3 standard deviations worse. So you times it by 30%. So whatever numbers you get with the putting the femoral neck in, you times those numbers by 30%. You don't add 30%, you times them by 30%. But actually that makes often very little difference So I think there's a slight problem with the model. But don't forget, if you have osteoporosis, you normally treat, and osteopenia is one where you have to just sort of bear in mind the issues with fracs. And for another example, which Astrid is raising, is that you don't put the site of the fracture in fracs. And as you can see here, the vertebral fractures are increase your risk 5 times more of subsequent vertebral fractures, and 2 to 3 times more of anywhere elsewhere. And that's more than any other site of fracture. So you have to use a bit of individual tailoring when using fracs. I hope that's clear. Okay, so here are some x-rays. Okay, so sagittal cuts, and you can see the x-ray, you can see this fracture very clearly over here. So that's L5 is the first one here, L5, 4, 3, 2, 1. So L1 fracture. Okay, and here you can see a CT with there's no actual fractures here, but there's a bit of loss of anterior vertebral height, perhaps up here. And then here's an MRI with this edema that I was talking about, showing recency of fracture. Okay, so let's go to the next question. And if I will pull it across, hopefully, remember that's the wrong code, so this is it. So which is a method for grading vertebral fractures? Is it Maslow's method, Genant's method, or Blatchford method? So Maslow staging, Genant staging, or Blatchford staging? Keep forgetting to hide the results. Not that was correct answer though. Let's see.
Can I just say, Alex? So yeah, I'll put the Menti code back in because that's quite confusing. The other wrong Menti code.
Yes, I'm not sure how that got changed. Might be okay. So the answer is Genant staging. Okay. Maslow's, I think that's a hierarchy of needs, and Blatchford is a GI staging system, isn't it? Okay, so Genant staging. So what is Genant staging? So I think we should all get in the habit of doing it. And sometimes you do a back X-ray, and then it takes 3 weeks to get a report, by which point, it's a long way down the line, and it's difficult to then change your approaches. So it's quite easy to read thoracolumbar X-rays. Okay, I just want to show you that very quickly. So this is how you would stage vertebral fractures. So there is a wedge deformity, so that's like your doorstop, okay, biconcave, okay, or crush, where it's at the back that's being crushed, okay. And you've got grade 1, 2, 3, and that's dependent on the amount of height reduction. Okay, so anything more than 20% is a grade 1 fracture. So all you really need to know is you need to be able to measure what is 20% less. Okay, so if I show you, so what I do in clinic is I will measure the front and the back, and if there's more than 20% difference between these two, so it would be A minus B over the first one, A, then if there's more than 20%, then I will call that as a grade 1 fracture. Okay, and if you want to do the biconcave, you also have a line in the middle, and it's a 20% drop from the maximum on one of the sides. Okay, so it's quite easy to do on the depending on your PAC system. Definitely on our one, it's quite easy to do, and you can therefore report your own X-rays and make a decision early on. Okay, so if we go down now to the treatment section down here. So in most vertebral fractures, the management of that actual fracture is conservative. Okay, there's 50% chance of sufficient pain reduction by 3 months. There's analgesia, early mobility, if they can tolerate it. Physiotherapy, especially with the spinal extensor exercises, so that the muscles can support the vertebra better. And there's some evidence for limited bracing and nerve root blocks, although these effects tend to be lost quite early. Okay. Vertebroplasty, kyphoplasty, mixed results. And don't forget, we need to address the bone health. So this is basically to prevent ongoing fractures. Okay. But the actual fracture itself, if you're worried, I would speak to the orthopedic spinal team or your neurosurgeons early on. If you're worried about this, often the patients will go there first, actually, then come back to us for ongoing bone health management. Okay, next. So intravenous zoledronate after a fracture, when should we give it? So you may note that in the BNF, it says you should give it 5 milligrams once yearly as a single dose to be administered over at least 15 minutes. That's fine. In patients with a recent low trauma hip fracture, the dose should be given 2 or more weeks following a hip fracture repair. Okay, so this is the controversial point here, 2 or more weeks following a hip fracture repair. Okay, so let's think about where that came from. And that's again the wrong code. So let me quickly bring that over there and here. So after a fragility fracture, fracture risk is highest immediately, after 6 months, after 1 year, or after 2 years. So after fragility fracture, fracture risk is highest. Is it immediately, after 6 months, after 1 year, or after 2 years? So let's have a look at the results. So the answer is immediately. Okay. Not sure why you would think it would be after 6 months or later on, but it's straight away. So let me show you the data. Okay. So this is a graph of your risk of next major osteoporotic fracture, essentially, plotted against time from your first fracture. So your first fracture here is at 0. And you can see here, if you fracture, your risk is super high in that first 2 years, and then creeps up with age thereafter. This dotted line is if you don't fracture, okay? So you can see here, there's this imminent fracture risk period, which is a new sort of phenomenon that's entering the literature, is about this imminent fracture risk and how we need to get on top of the fractures early, because they have this super high risk in the first, in the immediate post-fracture period, okay? So we need to start treatment as soon as possible post-fracture, especially as they take at least 6 months to work these treatments, okay? So I want to talk a bit about early zoledronate, so trying to give a patient zoledronate before they're discharged, after their hip fracture, after their vertebral fracture, after their humeral fracture, etc. And I want to show you a bit of evidence of the efficacy and evidence of the safety, because if you wait 14 days, they're often going to have gone home, okay? And then trying to plug them into GP services, fracture liaison services, trying to get them pick up their prescriptions, etc., will delay things considerably. So we should start thinking about giving zoledronate as inpatients, seizing the moment. Okay. So this is the original trial for zoledronate, the Horizon trial, done in 2007. Okay, so it was an international randomized, double-blind, placebo-controlled study, and a couple of thousand men and women who had a hip fracture. They were given Zol or placebo, and they were given their Zol if their vitamin D was greater than 37.5 nanomoles per liter. Now, our guidelines say 50 nanomoles per liter, and that's just for safety. But in this trial, they used 37.5, because remember, zoledronate can cause hypocalcemia. And so if you don't have a good vitamin D level so that you can absorb calcium as you're eating it, then you run the risk of hypocalcemia. So try and keep it above 50 in most cases. Okay, here they followed the patients up for 2 years. So where did this 14 days idea come from? Where did this idea that we need to wait 14 days before we can give Zol? Okay, well, it was a later study based on this data, performed by Erickson, published in 2011. Okay, so here what they did is they took the original Horizon study and they separated the patients according to when they got their zoledronate. So did they get it before 2 weeks, or between 2 and 4, 4, 6, 6, 8, etc. Okay, and then they wanted to have a look at the outcomes of these patients depending on when they got their zoledronate. Okay, important here, the first weakness is it's not randomized. They were not randomized as to when they were going to get it, and they were not blinded as to when they were going to get it, obviously. Okay, so the second thing to point out here is it's a much smaller group, this under 2 weeks. You can see 56 in the Zol group, 47 here, as opposed to around 150 in the other groups. Okay, so much smaller groups. It's going to be very difficult to tease out any benefits in such a small group, especially when fractures are rare. Okay. Next thing to point out, so fourth weakness is that this less than 2 week group here, okay, these are their characteristics, and you can see they're all older. Okay, so they have the percentage, so the one in brackets is higher for older people by far, so 26.5% are over 85 as opposed to only 13% in the other group, so the 2 to 12 week group. And they have a high, you can see all these numbers are higher, so they have a high incidence of all these other conditions. Okay, so the less than 2 week group was smaller, older, frailer, and more comorbid, and the study was not randomized and or blinded, so already biased towards worse outcomes. Okay, now the data they showed, so they separated the outcomes into the groups depending on when they got their zoledronate, as you can see here, and this is the HIP BMD at 12 months. So you can see here this very wide error bar. Okay, probably because it's a small group, very comorbid, and so you don't get definitive answers, but they were worried when they decided that it's going to be 14 days, or the recommendation of 14 days was that there didn't seem to be a significant improvement at the hip bone mineral density at 12 months, whereas the other groups it did. However, when you look at the 24 months data, you can see that there was a benefit at the hip at 24 months. So it doesn't make sense really for it not to benefit at 12 months, but to benefit at 24 months. So this suggests it just was poorly powered. And you can see the size of this error bar. Okay. So then clinical fractures, which was the main study primary endpoint. So they were a bit concerned about this as well. So under 2 weeks, there did not seem to be a reduction in your fractures as an endpoint. But actually, it was only in the 4 to 6 week group that they showed a reduction. However, if you group all of these together, there is a significant improvement or reduction in fracture risk if you give zoledronate after a hip fracture. Okay, again, you see this very wide error bar. So should we wait 14 days to give Zol based on this? So let's pull over the Mentimeter code again. Ignore that number on the screen, please.
I'll put the right code in again for the new joiners.
And I'm just bringing it over now. Okay, so should we wait 14 days to give Zol? Might be a bit of a leading question, I guess, but helps consolidate our thinking. So no, and I would agree with the no's at this point. Okay. So so I've shown basically that the 14-day recommendation. So you can give it before. It's not against the license, but just a recommendation. And we do that now here. We've just changed our guidelines to mirror that. The thinking that basically that 14-day data does not really show that there's no benefit, because at 24 months there is a benefit in BMD, and it's actually if you saw, the mean was higher than the other groups. So it's really quite weak data. So the other concern might be safety. Okay, does early zoledronate impair fracture healing? So the answer again is no. And this is another analysis from that paper. And here is the incidence on the y-axis, incidence of delayed hip fracture healing, depending on the groups. Okay, and you can see under the 2-week group, the delayed fracture healing was actually higher in the placebo group than the zoledronate group. Okay, but at no point was actually different. You can see the confidence intervals always cross 1. Okay, so it has no impact, and this has been shown in lots of other studies. So early Zol does not delay fracture healing, so you can appease your orthopedic surgeons with that.
Just explain that first. Do you mind? Yeah, that red bit. So it's higher. Is that a surprise?
So it's higher with placebo, yeah, but it's not statistically higher.
Okay.
Yeah. So essentially, it's higher with placebo.
Yeah.
The incidence of delayed. So the bad thing is the orange, yeah.
Yeah,
there's increased delayed healing with placebo than zoledronate, but not statistically significant. Basically, they're both the same.
Okay.
Yeah. So does early zoledronate impair fracture healing? No. Okay. And then I'll just show you some other fairly recent data where they've given zoledronate at 1 week post kyphoplasty. Okay. So this is a study looking at the effects of zoledronic acid in initial percutaneous kyphoplasty in patients with osteoporotic vertebral compression fractures. Okay, so slightly different setting, but still very relevant. And so they had 78 patients given Zol and 76 placebo at 1 week post kyphoplasty. And as you would expect, you get suppression of bone turnover markers, so the drug is working. I mean, there is a theoretical concern previously, for example, that the zoledronate would get trapped at the fracture site because there's very high remodeling and would not disperse around the skeleton. But here I want to show to you that there is good improvements throughout the skeleton. So the bone turnover markers are suppressed, as you'd expect, and the BMD improves. Here you see by 36 months, you've got this dramatic improvement, which is similar to if you gave it any other time, okay? So it makes no difference, this effect of giving it at 1 week. Then you say, okay, well, that's fine, bone mineral densities, but what about fractures? Okay, and you can see the risk of recompression of that same fracture is much reduced. So that's the blue compared to the green. Okay, so relative risk reduction of, well, it's an 80% reduction in risk, okay, given at 1 week or further fracture of that vertebra. And any new one, you've got an 88% reduction in vertebral fracture. Okay, so this study shows that giving it at 1 week improves your bone turnover marker, well, suppresses your bone turnover marker, so the drug is working. Your BMD improves by the same amount as it improves when you give it at any other time, and your fracture risk goes down as well, the same as when you give it any other time. Okay, so that's the 1 week data. And there's also recently a paper where they gave Zol at induction for the kyphoplasty, which is quite a clever idea. Okay, so so this is the effects of preoperative zoledronic acid on pain intensity after percutaneous vertebroplasty for osteoporotic vertebral compression fractures. Okay, and here they looked at the BMD at 6 and 12 months after the treatment, and they basically, so one of the things here you can see that the fracture rate went down dramatically, so it was 1.7% in the placebo and 1.7% in the zoledronate and 10.7 in the placebo group. So dramatic risk reduction in reduction in the fracture events in the Zol group when it was given at induction, and there were also significant improvements in the bone mineral density, as you'd expect. So this is when given at induction. Okay, so this is important because your fracture risk is highest just after a fracture. Patients are often discharged well before 2 weeks, and then they get lost in the community. Okay, it can take months for the FLS, the GP, and the prescription to address this bone health. And often patients are too frail to reattend hospital for a couple of visits for assessment, bloods, and an infusion. Okay, so definitely try to give zoledronate when you can prior to discharge, whatever day that may be. So just looking at the evidence that we went through, so fracture risk is at its highest just after a fracture. Early Zol does not delay fracture healing, very important to bear that in mind, okay? And then we talked about the 2 week horizon problems where they made that recommendation 14 days, a much smaller group, wasn't randomized, and it was older and frailer. And they did, however, have significant gains in bone mineral density at 24 months. So it doesn't quite make sense. It shows the problems with the design of trying to then stratify it according to weeks. And then we looked at the 1 week and the induction data, which shows robust improvements in bone mineral density as well as fractures. Now, one final point to discuss is how long do the benefits of zoledronate last? So let's see. So next question and final question is this. How long can a single dose of zoledronate benefit, reduce fracture risk for? So how long will it reduce your fracture risk if you just give a one-off dose of zoledronate? So single dose of Zol, how long is your fracture risk down for? Okay, so let's have a look. So a nice spread there. Okay, let's find out. Much longer than you think. So how long do the benefits of zoledronate last? So I just want to show you some data, okay, from a study where they gave zoledronate every 5.5 years, okay? And there are two lines you'll see on the graph. One is the Zol at the beginning and then Zol at 5.5 years, or the people got a placebo at the beginning and Zol at 5.5 years, okay? And there were 14 and 15 women in each group, okay? So this is change in spine BMD on the y-axis, change in total hip BMD on the y-axis down here, okay? So the group that got Zol first, obviously, as you'd expect, their bone mineral density improved, and look how it's staying up all the way through here, okay? And it's maintained when they're given another one. The placebo group are down here, and they're given their first Zol here, and it goes up there and is maintained again. It doesn't go quite as high, probably because they're older, so they get less benefit. And a similar pattern is seen here in the hip. But remember, Zol always works better on the spine, okay? So you can see here, you've got an increase in bone mineral density, and it's maintained for 5.5 years. And this pattern is also seen with the bone turnover markers. They only did the bone turnover markers for the second part here, but you can see the bone turnover markers do remain suppressed for much longer than you probably were thinking, okay? So they're not reaching these original levels up here for a very long time, okay? So single dose of Zol results in BMD gains maintained for over 5 years. So does this translate to fracture risk protection is probably what you're wondering. And the answer is yes. In this study, okay, so this is a study of 1 versus 3 annual Zol infusions in postmenopausal women. So on the left is the 1 infusion group, and on the right is the 3 infusion group, okay? And over 1,000 in that group, and over 6,000 in this group. And you can see here, so they all got their Zol or their placebo at this point. And you can see here, the two lines remain separated all the way through here for 3 years with a hazard ratio of 0.68, okay? If you give 3 infusions, so you give it every year, they remain separated as well. Hazard ratio 0.66, only 2% better, essentially. So 1 Zol infusion is giving you fracture risk protection for at least 3 years, And the bone mineral density graph I showed you before showed over 5 years of protection in terms of your bone mineral density. So this is another piece of evidence and another reason why we should use the opportunity to give a patient, especially a frail patient who may not make it back to hospital for their various appointments, a dose of Zol, because that will protect their bones for several years, okay? There's also an RCT of 2 Zols 5 years apart currently underway. So key messages: vertebral fractures are mostly asymptomatic, but they carry the highest risk of future fractures, so take them seriously, okay? Fracture risk is highest immediately after a fracture. Zoledronate benefits the bone mineral density and fracture risk when given from induction onwards. Zoledronate does not impair fracture healing, okay? Think zoledronate before discharge. Remember to make sure their vitamin D is above 50, they're normocalcemic, and their eGFR is greater than 35 to safely give your zoledronate. And remember, the benefits of that single dose of zoledronate will benefit their BMD for over 5 years and will benefit their fracture risk for over 3 years and probably 5 years in truth. So thank you very much. That's those 3 questions covered, and happy to take any questions.
That was really clear. Thank you very much, Alex. Any questions in the chat? I wanted to start off by saying, should we not then be giving all our fractured neck of femur patients induction anesthesia, a dose of Zol with the induction agent? That's what it sounded like.
Yes, yeah, no, I think that the trial needs to be done, and that would be a good opportunity. I mean, there is an argument on the MFE side, which is that they're very poorly at that point, and another knock to their system, because remember, about 20% of patients who get ZOL will have an acute phase reaction. It may not be the best time to go through that, but it may be, you know, it's about a time as any when they've just had their fracture, they're going to theatre. So you could argue that. But now in Imperial, we try and give it within the first few days of post repair. Ideally, we say day 5, but any time post fracture is fine.
And practically, is that before discharge?
Yes. So then they offer a discharge between days 10 and 14, and this was one of the reasons to make this improvement to our guideline, was so that we can ensure patients get zoledronate before they go home.
Yes, I think it's worth getting the BNF to change if we can do that.
Yeah, yeah.
Can I ask a practical question, Alex? Are you checking their vitamin D, because we did have a level of 50, or are you just pragmatically giving them vitamin D, and would you be concerned if their vitamin D was very low with this part, for example, 10? I can just think of a patient that's just popped up on our ward whose vitamin D has come back as 10, and obviously we know vitamin Ds don't come back straight away.
So yes, that's a very good point. And we have to think of the safety angle. So when patients come in, they should have their vitamin D checked to any fracture, and normally you'll get that within 24 to 48 hours. If it's less, and they should all then be put on Adcal D3, 1 tablet twice daily, or an equivalent. If the vitamin D comes back as less than 50, our protocol is to give 140,000 units of oral cholecalciferol stat, okay, and that will bring up your vitamin D very rapidly, okay, and there's data to suggest, and I can maybe show you next time, that within 3 days you've got vitamin D levels have gone straight up, including their activated vitamin D levels, so you don't need to wait after giving vitamin D really for a prolonged amount of time. Yes, it's very important. And if so, any time I would recheck it though would be if their admission vitamin D was less than 10. So if the admission vitamin D was less than 10, then I would like to recheck it prior to about 5 days post loading to check that it's gone above 50. But the other patients, I would be confident that it will have gone above 50.
Is your concern the calcium level or other factors as well?
So my concern is hypocalcemia post zoledronate. So you just want to get but patients who should be on, the most important thing is actually they're on Adcal D3. Yeah. And most studies show that if they're on Adcal D3, there's almost no chance of getting hypocalcemic. So whenever you see a fracture patient, immediately think calcium, vitamin D supplementation, and then get your vitamin D. That will come back soon, and then top them up, and then try and get that ZOL before they go.
Great, thank you, Alex. That was really practical. It'll have an impact on clinical practice for sure. So thank you very much for doing that. No problem.
Thank you very much for listening.
Not at all. Okay, we're going to move on to some cases now, clinical cases. I don't know if Aditi, you'd like to share your screen. In fact, it'll be Sandy's screen, I guess. Here we go. Okay, so Aditi's going to give us a clinical case. And again, if you've got questions, put them in the chat. But do you want to go on to full screen and then turn your microphone on?
Can you hear me?
Perfect.
Brilliant. Hi, everyone. My name is Aditi. I'm one of the endocrine registrars working at Charing Cross Hospital. Thank you for giving me the opportunity to talk through this case today. So this is a case that we recently had at Charing Cross. So meet Mr. NS. He, a 31-year-old male who presented to his local hospital feeling generally unwell, but his main symptoms were to do with low mood and recent suicidal thoughts. So going through the history, he said he felt generally unwell for a couple of months and really felt like no one could tell him why he was feeling this way. He had this background of anxiety, depression, suicidal thoughts. And his other two symptoms were that he had worsening bilateral leg swelling, which he had noticed over, again, the last couple of months. And he worked as a pharmacist, so he checked his blood pressures at home, and lately they were about 200 systolic. In terms of his background, he had diagnosed hypertension 2 years ago. He had this unprovoked DVT, a bit of a vague history back in 2015, for which he received anticoagulation for 3 months. And again, undiagnosed, but quite anxious, mental health issues over the last 1 year. And interestingly, looking through his previous admissions, he was admitted with E. coli bacteremia to his local hospital a year ago. Nothing exciting in terms of his medications. He was started on losartan for the blood pressure, and going through his detailed medication history, he denied any over-the-counter medications, no topical treatment or herbal remedies. And as I said, he worked as a pharmacist and lived at home with his wife and 6 children. Observations: he was very hypertensive in A&E with a blood pressure of 212 over 143, sinus tachy, afebrile. He had a BMI of 23. Quite anxious during the examination, but cardiovascular respiratory examinations were okay. He had a little bit of bilateral pedal edema, some central obesity, multiple striae over his abdomen and arms. And he said he noticed these back in 2008 and thought that those were just normal for him. These are the investigations that were sent out in A&E. He had a potassium of 2.7. His CRP was fine. His troponin, BNP, in view of the bilateral pedal edema, was negative. A&E also sent some thyroid function tests, which came back normal, HbA1c of 36. And in view of the blood pressure, they did a urine dip. So he had 2+ protein with evidence of microalbuminuria. His chest X-ray done in ED showed a widened mediastinum. So everyone got a bit excited. So he went ahead and had a CT aortogram, which showed unremarkable appearances, and they just thought this was projection, vascular projection on the X-ray. He didn't have any PEs. However, an incidental bulky left adrenal was picked up. Incidentally, I guess very topical after the last talk from Alex, he had bilateral rib fractures and vertebral compression deformities and pubic rami fractures, which were incidentally picked with no history of trauma in the background. And he was then admitted to the medical team, and soon after admission, he was the on-call team was asked to see him because of self-harm. So he had 2 lacerations on his left wrist. Psych were asked to see him, who asked for 1-to-1, and they said, oh, this might just be on a background of multiple psychosocial stresses and his illness. So just to summarize, we've got a 31-year-old pharmacist who presented with self-harm on a background of some anxiety and depression. He was hypertensive with low potassium. He had these incidental fractures, previous VTE, and a bulky left adrenal on the CT aortogram. I'm just going to move to questions. What initial blood tests may be useful at this stage? So you've got 4 choices.
Okay, also you can all vote for one of those. So I'm not going to count, there's no countdown on this. I will just give you 10 seconds, everyone. So everyone must vote, okay? I can see that not everyone has voted yet. Okay, 10 seconds. 5 seconds. Okay. There we go. So as you can see, most people put B. I I'm going to stop sharing. You can carry on. Okay.
Okay, so 87% chose B, and we had a couple that said C. So we did do the cortisol and the ACTH, which came back as a random cortisol of 906 with an ACTH of 186. What next investigation would you do to help you with your suspected diagnosis?
Okay, let me give you all 10 seconds. 5 seconds. 100%.
Brilliant. I can stop talking now.
We've got more to talk about. I'll just stop sharing.
Okay. I'll just share again.
I think if you just click on the anywhere in the slide, it'll start moving forward again.
So we did an overnight he had an overnight dexamethasone suppression test, and he had a battery of other tests after that. He was referred to the endocrine team. So his overnight dexamethasone suppression test, he had a cortisol in the morning of 820, and the ACTH at the time was 185. He also had a 24-hour urine-free cortisol collection, again, raised at 2,018 animals per liter, and the normal range is 50 to 70. His midnight cortisol was raised at 276. And then he had his whole pituitary profile, so prolactin was normal, IGF-1 was normal, he had a suppressed LH and FSH. The testosterone was an insufficient sample. And then because of that bulky adrenal picked up on the CTA autogram, he also had 24-hour urine, and because he was hypertensive as well and hypokalemic, he had a 24-hour urine metanephrine, which were normal, and he had a renin aldo when his potassium was actually replaced at 5, which was normal. He then went ahead to have an MRI. He went ahead and had an MRI pituitary, and the pituitary was reported as normal in size with no lesions. He had dedicated MRI adrenals, and these were reported as both adrenals being bulky, and an impression of whether they were myelolipomas in the adrenal glands. He also had a full body CT, including a CT neck, and that did not show any other malignancy. What is our diagnosis?
Okay, anyone else want to vote? 5 seconds. Okay.
Okay, so we've got majority with ACTH dependent Cushing's, which is the correct answer. So just a little bit about ACTH dependent Cushing's or Cushing's syndrome. Just is rare. The estimated prevalence from population studies is 20 to 40 cases in million inhabitants. It's important to exclude exogenous use of glucocorticoids, which is the commonest cause of Cushing's syndrome. And once that is excluded, then the endogenous causes of Cushing's can be divided into ACTH dependent, which is the more common, and then ACTH independent causes. So the case that we've discussed is ACTH dependent Cushing's, because if you remember, the cortisol was raised, but the ACTH was also raised. And the majority of causes of ACTH-dependent Cushing's is from a pituitary secreting adenoma, which is also referred to as Cushing's disease after Mr. Harvey Cushing's, an American neurosurgeon who first described it back in 1912. Or you can have an ectopic source of ACTH. So this gentleman went and had a full body CT to look for an ectopic source of ACTH. And the commonest cause of this tends to be small cell lung cancer or some NET tumors. ACTH independent is 10 to 15% of Cushing syndrome, and these are mainly from a benign adrenal adenoma or more rarely from an adrenal carcinoma. It's important to remember that there are cases of the features can be quite varied with Cushing's, but there are some features that are more discriminatory compared to others. So easy bruising, thin skin in a young person, proximal myopathy, striae, although they do not have high sensitivity, they are more discriminatory than some of the other features that are also present commonly in the general population, such as obesity, depression, acne, menstrual abnormalities. And again, this is just to highlight that it's important to remember that obesity and being overweight are common, both in the general population in gray and in the Cushing's disease population. But there are others such as osteoporosis, major depression that may be a bit more discriminatory compared to just obesity. Moving on to diagnosis. So again, there is no single gold standard test that can give us the diagnosis of Cushing's. And the most important thing is to have a good pre-test probability. And then choosing a test that would then have maximum sensitivity to detect the patients that have Cushing's. So this is the diagnostic algorithm that is from the Endocrine Society Clinical Practice Guidelines. So again, having a high pre-test suspicion of someone with Cushing's, excluding an exogenous cause of glucocorticoid exposure. And then they do recommend multiple different tests to look for concordance. And the main ones, and we know that each one of these have their advantages and disadvantages, and it has to be individualized to the patient in front of you. But overnight 1 milligram dexamethasone suppression test, as our patient had, or a 24-hour urine-free cortisol, late night salivary cortisol. So having at least 2 or 3 tests. If these are concordantly normal, then it's quite reassuring that the patient does not have Cushing's. If they are concordantly abnormal, then we need to then look for a cause of the Cushing's. Discordant results, obviously, if you have high suspicion, then, it could be cyclical hypercortisolism, or it may be someone who's got very mild Cushing's. So what the guidelines recommend is to then reassess at an accepted interval. So just to summarize, there's no single perfect screening test for Cushing's. A combination of screening tests are recommended. Pre-test probability is what's very important. So not just to do it on any obese, overweight person. And if you've got discordant results, then screen at an interval. So going back to Mr. NS, he was discussed at both the pituitary and adrenal MDTs. The pituitary MDT, he had his MRI re-reviewed, and that's where it's really important actually to have a dedicated neuroradiologist to look at these specialist scans, because although it was reported as a normal MRI, when it was looked at again, there was this query that there may actually be a small adenoma. However, important to exclude an ectopic ACTH secretion. So the patient was then planned for transfer across here for an IPSS, which we'll come to a bit later, and to have a repeat MRI pituitary at a center, and also to just draw a line under it to discuss his adrenal lesions that were picked up initially on the CT aortogram and then on the MRI adrenals. And in the adrenal MDT, they confirmed that these were bilateral bulky adrenal glands. However, these are consistent because he had a high ACTH5. So this is a T1 coronal image of his MRI pituitary. And as I pointed here with the yellow arrow, he had a very small hypoenhancing 4mm lesion, more so on the right side of the pituitary. However, he had a lot of space, so there was no suprastellar component, and it was not affecting the cavernous sinus. What would you like to do next?
It was Cushing's disease. The whole endocrinology community in London thinks I'm an idiot.
Okay, so 86% with inferior petrossal sinus sampling and a couple with AVS and OGTT. So he did go ahead and have an inferior petrossal sinus sampling. So this is an invasive test. So it's bilateral inferior petrossal sinus sampling, whereby ACTH is measured in the pituitary veins, which drain the pituitary, both on the right and the left. And this is compared with the peripheral ACTH levels to see if there's a gradient between the central and the peripheral and the periphery. Again, it requires really good skill, so to be done in centers that have good experience with it. And the main purpose of this is to distinguish it from ectopic ACTH. It should not just be used to diagnose Cushing's. So this is our gentleman, Mr. Ennis's IPSS results. So just to orientate, so we've got plasma ACTH. So this is from the left petrossal sinus, right, and this is the peripheral vein. The plasma cortisol in the 3 sites, and then the plasma prolactin in the 3 sites. And we've got time. So if you just have a look at this, the next question is going to be related to the interpretation of this. So what does the IPSS suggest? Does it exclude ectopic source? Does it confirm an ectopic source? Sorry, I've got a few more options. Does it exclude Cushing's?
So do you want to go back to the numbers? They'll remember that. So A is exclude Cushing's, B confirms ectopic ACTH, or C excludes Cushing's.
Yeah. Bear with me.
Okay, so we'll have a careful look at that. And now they need the options because they can't remember what.
Oh, sorry.
We're up to. Doesn't go over this. Can you go forward to the 3 options again?
So excludes, confirms, so excludes ectopic, confirms ectopic, or it just excludes Cushing's on itself.
Okay, we've got a few more votes now. I can see them coming in. Okay, let me share the results.
Okay, so we've got 75% excluding ectopic source of ACTH. There were a couple that confirm. Okay. All right, I'm going to go back to the results. Okay, so just to be, so the three catheters, one in the peripheral vein, one in the right petrosal, one in the left petrosal sinus. The prolactin is measured just to ensure that we've got correct catheterization. So there should be a gradient between the periphery and the petrosal sinus. So here we can see that there was a little bit of struggle in cannulating the left petrosal sinus. However, the main thing we want to look at then is the ACTH. So if we look at the peripheral vein, we've got levels between 140 to 357. And then when we look at the right, they're quite high, much higher, going up to 2,400. And to be fair, even in the left, although difficult cannulation, they're much higher than the peripheral vein. So there is a central to peripheral ACTH gradient.
You want to just put it there and just see if has anyone got any questions about this? This is very important because clinically, or called that low potassium, so a lot of people would have thought that it would be ectopic ACTH, but that's simply because it's got such a high cortisol, I think. Any questions, anybody? You're all happy with this? There are a couple of things. You're quite right. The right petrosal sinus is correctly cannulated because the prolactin is higher, like 800. Yeah, at the bottom there. Astrid, do you want to unmute?
Yeah, the reason I did answer all the other questions, but I didn't answer this question because I thought it was, and maybe it's just the wording. I didn't think that it was the test was designed to exclude ectopic ACTH secretion. It was designed to confirm whether the patient has pituitary Cushing's.
Okay.
And so, I agree. I mean, I think looking at that patient looks like, I don't know, but it looks like they have pituitary Cushing's, but that doesn't necessarily exclude a really, really rare case where they have both an ectopic and a pituitary.
So you're quite right. I'll tell you what, Astrid, though, the wording is really important because I've stopped saying confirmed pituitary because the problem is you'll get the same result in a normal person. So if you have an IPSS, we'll call it pituitary. So all we can do, in fact, with the IPSS is say, he hasn't got ectopic, he might be normal. Do you see what I mean?
Oh, I see.
So I'm keen to get away from saying it confirms pituitary because I've seen a number of patients who have had IPSS done at other places where the patient actually didn't have Cushing's at all. And then they said, oh, it's pituitary. The source is pituitary. But actually, they should have said it excludes ectopic ACTH. We don't know if he's got Cushing's at all. And that way around is the safe way to go. But I take your point about very, very rare dual tumors. But I think it's important to get away from saying this confirms pituitary. That's the message I'm trying to give. But thank you for that question. Any other thoughts or? Okay, do you want to carry on then, Aditi?
Yeah, so just moving on to treatment. So again, these are the Endocrine Society clinical practice guidelines. Surgery is the mainstay of treatment. So if it is ACTH dependent, then transphenoidal surgery, and you can use adjunct medical treatments. If there's recurrence, then considering repeat transphenoidal surgery, as well as radiotherapy. And obviously, if it's ACTH independent, then based on your adrenal imaging, then considering adrenal surgery. In terms of medical therapy, there are a couple of options. However, they can be challenging and it needs to be individualized to the patient in front of you. But just broadly speaking, you have medications that inhibit the adrenal steroidogenesis pathway. So we've got ketoconazole, metarapone, mitotane, etomidate, which is parenteral. We've got medications that directly antagonize the glucocorticoid receptor and actually the progesterone receptor, and medications that work to suppress the ACTH secretion, so the somatostatin and the dopamine agonists. And again, the society guidelines have a little bit more on this, looking at the pros and cons of each of the different medications. So our gentleman was started on metarapone, which works quickly, although it does have a side effect profile, but this was just because he was so floridly Cushing's that whilst he was awaiting transsphenoidal surgery, he was put on metarapone, and actually his cortisol levels did come down, his hypertension and hypokalemia did improve, and then he was booked for an inpatient surgery. And this is just as a reminder that cortisol does have a diurnal rhythm, and this is lost in Cushing. So the pink here is normal individuals, and then the purple here is patients that have high cortisol throughout. So we did a cortisol day curve on Mr. NS whilst he was on 1 gram 3 times a day of metarapone, and that's just for us to kind of get a bit of a diurnal rhythm back and reduce his cortisol levels. So as you can see here, his cortisol levels did improve through the day on this treatment. Not perfect, but better than prior to treatment. And just briefly, obviously this gentleman had a background of depression, anxiety, suicidal ideation, episodes of self-harm in hospital. So it's again important to remember that patients can present with psychiatric symptoms with Cushing's, and they can be as high as 83%. The main one is depression and panic disorder. Acute psychosis is rare, but it has been reported in case reports. And these symptoms can be in the prodromal phase, it can be during the illness, and they may improve after treatment, either with medical or surgical options, but they can even persist way after remission. So it's important to follow these patients up long-term in terms of their psychiatric health. So this was a systematic review that was recently published looking at the impact of treatment in patients with Cushing's on their neuropsychiatric symptoms. And they found that majority improved, although about more than a quarter did not achieve complete resolution. The medical treatment also did help their psych symptoms. 96% of patients who had depressive symptoms had improvement after treatment. So Mr. NS, his mood did improve after TSS. The surgery was uncomplicated. His proximal myopathy has also improved, but he's getting ongoing community physiotherapy. And he was discharged on prednisolone 5 milligrams once a day. He was subsequently discussed in our pituitary MDT and with his histology results and his post-op MRI results, which showed a good resection, and his histology did confirm a pituitary adenoma that expressed ACTH with a Chi67 of 3 to 4%. He's now being followed up with post-op cortisol levels, post-op ACTH levels. And this is his latest cortisol day curve after his operation, whilst he's on prednisolone 5 milligrams. So if you remember the previous cortisol levels on metarapone, and we also do prednisolone levels, and his 8-hour level was 36 on 5 milligrams. Which shows that he's adequately replaced. But paradoxically, most of these patients with Cushing's disease after surgery feel worse off, and it's this whole cortisol withdrawal syndrome. So, he's been feeling all the symptoms of cortisol withdrawal because he's so used to having such a high cortisol that we've, if anything, had to increase his prednisolone to 6 milligrams in the short term.
In fact, we've done that because he came up.
Yeah.
He's now on 6. Just go back one slide just to talk to people about these two curves. So cortisol, he's cured, as you can see. His cortisol levels right down from 800. And so in order to protect it on an adequate replacement, normally, of course, we want to be on 2 or 3 milligrams of prednisolone because you want to get as little as possible, but they feel so Addisonian because they're so used to high levels that we will have to wean him down now. He's now on 6, and then we'll wean him down to get into a normal curve in about 4 months, the last patient took to feel better.
Yeah. So just to summarize, Cushing's is a rare disease. It can present slowly, but there are significant, it does present with significant morbidity and mortality. So it's important to get the diagnosis correct and treat it promptly. Again, important to remember the sequelae of, thrombotic events. And at our center, we these patients do get anticoagulation with rivaroxaban pre-op as well as 3 months post-op, because especially ACTH dependent causes of Cushing's have high VTE risk compared to ACTH independent causes as per the literature. And again, being wary of infections, cardiovascular mortality, bone health, and neuropsychiatric symptoms, and important for them to be assessed by the psych team and have that ongoing follow-up, because the symptoms may improve but they don't completely resolve in some patients. And I think most importantly, especially with this case where initially he had a bulky adrenal, we're thinking this could be an adrenal source of his Cushing's, but having an MDT approach is so helpful to ensure that they get the correct investigations and timely investigations, and ensuring that they are followed up to ensure in the right replacement, hormonal replacement, and that is adjusted according to their symptoms and biochemistry.
Great, thank you very much. Any questions from anybody? That was a great case. So, Dr. Kapoor, question to mitapirin uses. Anecdotal experience in using block and replace. Yes, we're doing a bit of both, to be honest. So patients who are waiting for a longish time can go on block and replace, and that means you use something like a gram 4 times daily. That's 4 capsules 3 times daily, or even 4 times daily, and then a bit of prednisolone. So prednisolone 3 milligrams once daily. We've got a couple of people on that, and they're waiting for surgery, not because of a waiting list, but because they have another disease that needs a more urgent treatment. So yes, block and replace is an option. So we use, I'll just say again, a gram QDS of mitapirin a lot, and then you add prednisolone 3 milligrams once daily. Or you can use just mitapirin and titrate the dose up, and that's what this patient had, and she had quite a nice curve. Any other questions or worries? I don't know if Sandy wants to get your slides ready while people are thinking about questions. The other thing, I'm glad that we didn't talk at all about high dose DEX suppression tests, because of course in this patient it would have been misleading, because you'll notice, if you remember, the post low dose DEX cortisol was 820, so it didn't move with a bit of DEX, and so it would have pointed us towards ectopic ACTH, which is what the potassium pointed us towards. And the only way to get the right source is to do an IPSS. So high dose DEX suppression tests are history because they're misleading. Do you want to share your slides, Sandy? Oh, not Sandy, sorry. Lisa, I got it in the wrong order. Lisa, are you there?
Hi, Prof. Yes, I was just wondering that. Yes, I'll share my screen now.
Yes, please. Apologies. Have you got any questions that you want me to use the poll thing for?
I don't, it's not as interactive as DTs, but please feel free to stop me at any time if there are questions on the chat.
I'll do that. Okay.
Can everyone see my slides?
Yeah.
Perfect. Okay. So hi everyone, my name is Lisa. I'm an endocrine registrar at Hammersmith Hospital, and thank you for the opportunity to talk through this case. This is a case that was actually presented by my colleague, Dr. Manish Modi, at the Petrossal Masterclass. Some of you may remember the presenting features, and then there's been an interesting journey since then. So this is a 33-year-old lady with a background of obesity, primary hypothyroidism, and polycystic ovarian syndrome. She presented to Charing Cross Hospital on the 6th of May in 2021 as a stroke thrombolysis call. And the symptoms were sudden onset, severe headache, 3 episodes of vomiting, and she was unable to open or move her left eye and was complaining of diplopia. So on examination A&E, she had a GCS of 15 out of 15, but a complete left ptosis with a dilated left pupil, and she was found to have a complete left, 3rd, 4th, and 6th cranial nerve palsies. There was no deterioration of visual acuity, reassuringly, and no other motor or sensory deficit. She went on to have a CT hair and a CT intracranial angiogram as part of the stroke call, which showed no acute hemorrhage or infarct, but there was suspicion of a short segment dissection within the left internal carotid artery with moderate luminal narrowing. And based on this, she proceeded to an MRI and an MRA. So this is her MRI on admission. And it shows a large cellar mass here with small volume hemorrhage extending to the left cavernous sinus, and the appearances were concerning for pituitary apoplexy. There was superior displacement of the optic chiasm, but no compromise or compression. So on recognition of this, she was urgently referred to the neurosurgical team and the endocrine team for review, and she received immediate IV hydrocortisone. From the neurosurgical perspective, they advised that intervention was not required at the moment due to preserved visual acuity and GCS, but she went on a daily review by the neurosurgeons. The endocrine team reviewed and requested a pituitary profile. They commenced on regular oral prednisolone and interrogated the history a little bit further. So on further history, this lady had had a 45-kilo weight gain over 3 years. She had acne on her face and breast that developed over the past year and easy bruising. She'd also had secondary amenorrhea for over a year and was hirsute. This was more long-standing. And interesting, she had a child, a son, aged 5. She's been hirsute since then. So she'd previously also been investigated in 2013 for subfertility and weight gain, with weight gain about 30 kilos over 10 years and oligomenorrhea. She did have a low-dose dexamethasone suppression test at the time, and she adequately suppressed her cortisol, so the diagnosis was felt to be more in keeping with PCOS, and she was commenced on metformin. So on examination, she had a plethoric face with an interscapular adiposity. She had acne, scarring, and also moderate hirsutism. There was central obesity with a weight of 146 kilos, multiple bruises, and evidence of proximopathy with difficulty rising from a squat position. She did have striae, but they were not violaceous. So the clinical picture was felt to be consistent with Cushing's disease or pituitary Cushing's, and that's presented with apoplexy. This is her pituitary profile on first admission. The TSH is raised, which is in keeping with her history of primary hyperparathyroidism. She's got evidence of secondary hypogonadism with low gonadotrophins and a low prolactin. And she had a very high cortisol, but this was probably measured after IV hydrocortisone had been administered. So her inpatient progress, while she was admitted, she was discussed at the pituitary MDT, and the MDT felt that it was best to have conservative management with close surveillance in accordance with Society of Endocrinology guidelines, as she had normal visual acuity, preserved visual fields, and normal GCS. And in fact, actually, she was discharged 5 days post-admission. with a 9 AM cortisol of 513, a non-suppressed cortisol after an overnight dexamethasone suppression test. So she was discharged without glucocorticoid replacement, and she had her levothyroxine dose increased based on her raised TSH and weekly review in endocrine clinic. So she did quite well. At 6 weeks after discharge, she had complete resolution of left-sided ptosis, normalization of her eye movements, and minimal residual double vision after conservative management. And then at 3 months, her weight had gone down to 140 kilograms, and her gonadotropin levels were normalizing. Her platinum come up, but her periods are yet to resume. So it's felt that potentially this is a lady who has actually potentially cured her Cushing's with a pituitary apoplexy. But her follow-up continues. So she then went on to have some follow-up pituitary MRIs. So on her initial MRI, she had this heterogeneous cellular lesion with the supracellular extension. At 6 weeks, there was resolution of the heterogeneous signal. There was felt to be some residual areas of hyperenhancement on the left side of the gland, however. And at 4 months, she has another MRI pituitary, which then reported as seeing no real discrete lesion and possibly some more heterogeneity on the right of the gland. So a little bit discordant here. She also then had some serial cortisol day curves, which I like to talk through now. So as mentioned before, she was discharged, so 2 days before this, on the 15th of May, with a non-suppressed cortisol after a dexamethasone suppression test. However, 2 days after discharge, her cortisol day curve showed quite low cortisols, under 80 here. So she's actually started on some prednisolone here in May. And then a month later, she had repeat cortisol day curves with more normalization of her cortisol axis. So the prednisone felt to be stopped, and it was felt that she was recovering her axes. She's followed very closely in the subsequent months, and in August, you can see her cortisols are going up again, but she maintains a circadian rhythm. However, in September, you can see further rise in her cortisols throughout the day, with ACTH of 48.7 at 9 o'clock, and potentially a loss of circadian rhythm. And we are now wondering, has this lady's Cushing's disease relapsed? She was then discussed at the pituitary MDT on the 30th of September, and the concern was that there is now functioning ACTH producing tumour following apoplexy, and that her latest MRI pituitary 4 months on from her apoplexy shows heterogeneous changes, but no clear lesion for a surgical target. So the MDT plan was to perform a dynamic test as a 48-hour low-dose dexamethasone suppression test, confirm whether she is producing autonomous cortisol, and discuss about obtaining a methionine PET scan to help identify residual disease, and I'll talk about that a little bit later. This, on the 4th of October, she went and had a low-dose dexamethasone suppression test, and this shows non-suppression of cortisol at 48 hours. This is 100 with an ACTH of 103. She also had a midnight cortisol of 287 on this occasion, with a salivary midnight cortisol in the normal range, but a raised midnight salivary cortisone of 22.2. So I'm just going to stop there and say, is there any questions so far?
There was something in the chat I just saw. I'll just have a read of it. On what grounds she started on pred as an inpatient, as a precaution? Yeah, well, that there was some there was lowish, although she didn't suppress, she had the lowish cortisol, like that one there. See, 43.79. I think that's it's a bit tricky to let them go home without any steroid at all. So that's the reason. Any other questions? So when we presented this at the pituitary meeting, that was in early September, we were looking like, she's cured herself with an apoplexy. Amazing. That's, as you're about to tell us, there's a bit more to the story now.
Yeah, so sadly, by August, it looked like maybe she's just normalised, and the hope was actually to stay like that. But sadly, as we saw from September onwards, did look like her cortisols were going up, and then she also did not suppress. So based on this low-dose dexamethasone suppression test, she went on to have some more cortisol day curves, actually. So in October, she had a cortisol day curve here. She's not on any treatment, she's not on any prednisolone. These are her cortisols from 9 until 6. She's a midnight salivary cortisol that evening, and then she's also given some metyropone 500 milligrams here on the 19th of October. The next day she has a repeat cortisol day curve, which has shown possibly minimum response to 500 milligrams of metyropone. So then the metyropone is then increased, and she's now on metyropone 750 milligrams with repeat cortisol day curve the day after, also showing possibly not much response in terms of her cortisol levels. She remains on metyropone 750 milligrams. Then she, between November and December, her clinical progress is that she actually had an inpatient admission at the end of November with pain secondary to a dental abscess, and she came to Charing Cross Hospital and actually awaited a tooth extraction by the maxillofacial team. During her inpatient admission, she had numerous cortisol levels taken, and actually they remained high. So metyropone then was up titrated to 500 milligrams twice a day. She had a further up titration with time. She's seen very regularly in endocrine clinic and also on the plan investigation unit, monitor cortisol. She then goes on to 500 milligrams of metyropone at lunch and a gram at 6 p.m. Based on her cortisol day curves. She's unfortunately missed a methionine PET appointment because of her inpatient admission, and this was rescheduled for the 21st December. And I had to educate myself a little bit about methionine PET imaging and its utility, so I thought I would tell you what I know. It's not a huge amount. So 11C methionine PET is a 11 carbon radioactive tracer attached to methionine, which is the first amino acid incorporated into all peptides. And then when you have radioligand methionine, it's a very useful tracer for identifying sites in the body with increased peptide or protein synthesis. The anti-pituitary hormones are mostly peptide or protein hormones, so this is an ideal site that takes up methionine very well. And it's been found in early studies that compared to fluorine FDG, methionine is more preferentially taken up by even the normal pituitary gland compared to the surrounding brain. And most pituitary adenomas have enhanced 11C methionine uptake, and so it offers more advantages to either a somatostatin receptor ligand or FDG. And certainly an area in circumstances where there's been tissue modeling of the pituitary, for example, post-operatively, where you're looking for residual tissue or after radiotherapy. And then in this case, after some partial damage to the gland from apoplexy, 11C methionine PET can be a sensitive technique for detecting residual pituitary disease. So she waited and had her 11C methionine PET in Cambridge, and then she was discussed again in January this year with the results. So the methionine PET showed that there is certainly residual necrotic tumour left on the left side of her pituitary gland, and unfortunately extends more inferiorly and posteriorly than initially suspected into the cavernous sinuses and around the exit optic nerve. There's possibly some uptake on the right as well, which is likely to be functional because it's taking up the methionine tracer. So it's functioning pituitary gland, but it's difficult to differentiate. So based on that, as a lady who has previously initially presented with an apoplexy, we thought initially that potentially she has resolved her ACTH excess and Cushing's disease through the apoplexy, but unfortunately her cortisols have sequentially risen and stayed high despite medical management with metyropone, and she's now had a methionine PET imaging showing residual tumour in the gland extending into the cavernous sinus. What might her management options be, was the question to the MDT. Does anyone know, or does anyone have any ideas what they would like to do?
Any thoughts from anybody? It's worth saying that unlike the first case, where there was a nice, possible tiny 4mm target that Aditi showed in the first, patient who had Cushing's, once you've had apoplexy, your anatomy is very tricky. If there was a lump there, it's infarcted and you don't know what's where. So this was a very useful test. So we could have a multiple choice, couldn't we? But anyway, our options, I guess, are operate on the pituitary or something else. Any other thoughts from anybody?
Well, I'll tell you what the MDT thought then. Sorry, what was that?
Go ahead.
I'll go ahead. I'll say what the MDT was. So the MDT outcome was that from a neurosurgical point of view, they felt transsluminal surgery would be unlikely to provide a cure for this patient because of this residual disease that's in the left hand sinus. It's a difficult operative field. And it was asked to discuss bilateral adrenalectomy for her as a management of her hypercortisolism, and then also to consider pituitary radiotherapy post-adrenalectomy. Now, I haven't actually met the patient, but I feel that the decisions around having her go for a bilateral adrenalectomy may be influenced by the fact that she would like to conceive again, and potentially go for bilateral adrenalectomy rather prior to pituitary radiotherapy may be more beneficial for her in terms of the conception in the future, maybe.
That's what she wants. Yes, you're quite right.
So this was discussed with the patient. It was a bit of a shock that she won't be able to have a cure from having this transfemoral surgery, but she did agree to go for bilateral adrenalectomy, and she had this done on the 30th of March 2022, last month. Prior to surgery, she had a CT adrenals, she had normal morphology of both adrenal glands and no nodularity. And preoperatively, she was on metarapone, a gram BD, rivaroxaban for VT prophylaxis, because we know there is an increased risk of thromboembolism in HCTH-dependent Cushing's. Her preoperative weight was 143 kilos, and her last cortisol taker performed on a gram of metarapone twice daily is here, with a 9 AM cortisol of 466, and some return of her circadian rhythm, I'd say, in the afternoon and evening.
So that's because we gave the metarapone at noon and 6 PM to try and have a higher level in the morning than in the afternoon. So it's sort of artificial.
So Schifferl, she had her adrenalectomies under Mr. Marco Hammersmith, and then came back to ward after 3.5 hours of surgery and being in recovery. On her post-operative day 0, on that evening, she was reviewed by the on-call doctor because she said that she actually had developed a headache, numbness of the left side of her face with double vision after the surgery. They were obviously worried with her history of apoplexy, and a non-contrast CT head was arranged that evening. This was reassuring in not showing any acute intracranial pathology or features of pituitary apoplexy. She was given prophylactic noxaparin 40 milligrams BD post-operatively, and she had prednisolone 5 milligrams and fluticasone 50 micrograms prescribed for the following morning, day 1 post-op. So next morning, she had some cortisol levels taken pre-prednisolone, which shows surgery was reasonably successful, was very successful with a cortisol level of less than 20. I met her on this day, reviewed her at 9, and she was still complaining of a headache and diplopia, and she still had numbness over kind of the second trigeminal branch region of her left face, with diplopia on left-right gaze, but normal eye movements and normal visual fields. Unfortunately, prednisolone and fluticasone hadn't been given, and they didn't get given until about 10 o'clock and lunchtime, respectively, that day. 5 o'clock, I went back to see her to make sure she'd actually had some of her steroids, and her headache and diplopia were improved. Despite receiving her prednisone and fluticasone, she was still very dizzy on sitting up and hadn't mobilized out of bed, and she is 143 kilos after a major abdominal surgery. She developed a new oxygen requirement, desaturating to 87% on air and had sats of 93% on 3 liters of oxygen. She was tachycardic, and she was moving air very poorly throughout her chest. After discussion with Dr. Vernick, we gave her a stat dose of fluticasone to give her a total 100 micrograms of fluticasone that day, and then increase her fluticasone for the next day. She had an arterial blood gas which showed type 1 respiratory failure with a normal pH of 7.45, and bilateral atelectasis on chest x-ray with a lower lobe consolidation, and reassuring her CTPA didn't show a central PE. She does start spiking fevers then by the next day, and we've commenced her on oral comoxiclav for post-operative pneumonia. Her prednisolone gets doubled to 10 milligrams for the next 48 hours while she's acutely unwell, and she has chest physio. Also, she does very well. Her oxygen requirements go down, her fever settles on comoxiclav, and she's discharged on post-operative day 4 on oral comoxiclav Prednisone back to 5 milligrams on stage replacement and 100 micrograms of fluorocortisone, and she will remain on rivaroxaban 10 milligrams once daily for 3 months post-operatively. She's got a follow-up with the endocrine surgeons tomorrow, seeing the endocrine team in May, and then she's going to discuss pituitary radiotherapy with the oncology team in June. And that is that. So in summary, this lady who presented with pituitary apoplexy on a background of Cushing's disease, following conservative management, she was able to regain complete recovery of her cranial nerve pathology, and despite initial low cortisols, also recovered her pituitary hormone reserve. However, unfortunately, with serial testing of cortisol day curves and follow-up, she did relapse from a Cushing's perspective. And in this circumstance, where there is damaged pituitary and scar tissue after apoplexy, 11C finding PET did provide crucial imaging information that has aided further management. And a multidisciplinary team discussion was extremely important. It's very complicated. A young patient with bilateral adrenalectomy managing to provide control of her Cushing's. She was, however, a very high-risk patient still for this operation, leading to a complication of post-operative pneumonia. She remained on 3 months with Roxban to prevent VTEs, and she now will have lifelong glucocorticoid and fludrocorticoid replacement.
Great, thank you very much. Any questions? I thought it was very nicely done. Oh, in fact, there's some questions for us. How can we monitor for relapse of pituitary disease following that? Any thoughts? What we're going to do is do regular ACTH levels at the same time after her pred every day, or not, each time it's done, and of course imaging. And if a visible lesion appears, then we could maybe operate on it again in 5 or 10 years. But until then, she can get on and have her family. Again, this patient, we will titrate down her prednisolone dose when she feels better, because patients after Cushing's, they're so used to very high levels that I struggle to get them onto their normal dose of 3 or 4, but eventually they will. Within a year, she will be on, I hope, about 3 and be much better.
I had a question, Prof, actually, just go for the case as the lady I've actually really met for. She's got quite a large, would you say she has quite a large residual, or certainly was just going to a cavernous sinus? In this person who's now had a bilateral adrenalectomy, is she at more risk of getting Nelson's?
Yes.
Because of what's left, and that's why radiotherapy is quite important.
Yeah, it's not big. The problem is it's where it is. So it is important. It's where it is. Now Nelson syndrome, we're all very scared of, but in fact, now that we've got such good MR and such good imaging, we can catch it and irradiate. If we wait a year or 2, we wouldn't have done this in the past when we had not such good imaging. But now we can watch very, very carefully for any growth and then irradiate it when we have to. The thing about
you wouldn't have routine radiotherapy, we would just have serial imaging and only radiate if there were concerns.
Yeah, I mean, we've done this. There are other patients who have had this. I mean, before about 1980, everybody had adrenalectomy. That was the only treatment.
Yes.
And we used to scan them regularly. And some of them have still not had radiotherapy after many years. So because it doesn't always come back or grow or become a big problem.
His name?
There's a question from somebody I can hear. Who's that?
I'm doing it.
Somewhere. Okay, listen, does that person want to mute? I don't know who it is. You want to mute, Lisa, and then we'll move on to...
Yeah. Okay. I'll just stop sharing.
Yeah. Okay, so now the last case is fight or flight. It's a nice enigmatic term. Want to share your screen, Andy? Great. Why don't you
Hi.
start?
Yeah, can you hear me?
Perfect.
Hi, good afternoon, everyone. My name is Sandy. I'm one of the endocrine registrars from Charing Cross Hospital. Today, I'd like to present a case. Yes, we gave the name as fight or flight because the patient is actually on the way to his flight. So this is a history. He's a 51-year-old gentleman currently living in Abu Dhabi, and he flew to London for 24 hours business trips. His past medical history is only having hypertension for more than 10 years, and he's on olmesartan and hydrochlorothiazide once a day. So at the airport in the queue, he called 111 because of the worsening headache. Thus, he was taken to the nearby local hospital. And on A&E in the local hospitals, he told the team that he has had headache for 3 days, which is a frontal generalized headache, which has been worsening overnight. And also he noticed that he has been unsteady on his feet. And he said he has loss of his peripheral vision. That this is the complaints in the ED. So he's otherwise fit and healthy gentleman. He has no prior history of headache or migraine. However, a few years back, he reported he's got low libido and lack of morning erections. And he went to see in the women clinics in Abu Dhabi, and they said he has low testosterone levels. He has not been taking any hormonal replacement until now. He has children who are in their 20s. He lives with the family in Abu Dhabi. He's non-smoker. He's not a drinker. He's a retired military pilot and currently working in the aviation industry. The relevant physical examinations and bloods for his GCS is 15 out of 15. And the ED team did the visuals field examinations, which shows that he's got a significant bitemporal hemianopia on bedside confrontation. His blood pressure is mildly raised at 170 over 100, and the bloods, which were done at 9 p.m. in ED, which shows that he's got white cells 10, HB is normal, platelets 206, CRP is 6.7, and TSH and free T4 is normal, prolactin is 117, cortisol is 41, and it's 9 p.m. And his testosterone is 0.8, LH is 0.5, IGF-1 is 29.8, and FSH is 3.1, which is normal. So my first question is, while we're waiting for further investigations, and what is your provisional diagnosis of this gentleman? He's a 55-year-old gentleman, fit and healthy, acute headache, and he's got visual disturbance and postural instability.
Okay, let me go at 10 seconds.
Perfect.
Okay.
Right. Yes, he had an MRI with contrast, but actually he had a CT head first, and we didn't have the CT head from the local hospital. So this is the MRI, and you can clearly see that he's got a mass pituitary macroadenoma, and you can see some hemorrhage there, and the most importantly, he's got this upward compression of his optic chiasm, which you can see clearly here in the middle scan.
So he must have had that big tumor there for quite a while, not known, and then it's hemorrhaged and just pushed on up the chiasm, and he's got an amazing bitemporal hemianopia.
Yep.
Mm.
So yes, he's got 26 millimeter pituitary macroadenoma, and with internal hemorrhage and left cavernous sinus invasion, and the optic chiasm is displaced superiorly.
Just go back one, just go back to the pictures again. This that cavernous sinus invasion is very important, okay? Because if there is cavernous sinus invasion, it makes it difficult for the surgeon to take it all out. But if there isn't, then they can get the whole thing out. So there's a tiny bit there, And so it'll be difficult for them to remove all of the tumor. But of course, we don't think this is a functioning one, so it doesn't matter quite so much as in Cushing's patients. Okay, thank you. Do you want to?
Yeah.
With your second question, I'll do the same. I've only got options of 5 options. I see you've got 2
So 2 options.
Okay,
So because we make the diagnosis as a pituitary apoplexy, and Lisa already mentioned about another pituitary apoplexy in her presentations. But for this patient, what is the management plan? We're going to give him hydrocortisone because of his low cortisol, and are we going to manage him conservatively, or needs this urgent surgical decompression?
So just vote for A or B. Okay, I know you've got 3 other options. Just choose A if you think we could manage conservatively, or B if we think we should. Okay, you all 10 seconds. Come on, everybody, you must vote, okay? 5 seconds. Okay, let me share the results.
Right, so 73% wants the urgent surgical decompression, and 27% wants to manage conservatively.
Yeah, good, okay.
Okay. So I will go into details about this. How do we manage like either conservatively or the surgical decompression? But for this patient, he was urgently referred to the neurosurgeons, and then he was transferred to Charing Cross Hospital overnight. And he had an urgent transsphenoidal pituitary surgery. I think it would be within 24 hours on arrival. And this is his post-op MRI. You can clearly see that his optic chiasm is free from tumors now. And there is another image which I can show you with compared to pre-op and the post-op MRI.
Thank you, that's really clear.
And unfortunately, we didn't have the visual field assessment, but he was very kind of like, he had loss of his peripheral visions, and on examination, it was quite clear that he's got bitemporal hemianopia. And so he was straight to the surgical decompressions. However, we have this post-op visual field, and I think we still can see that he still has some loss of his visual field. However, subjectively, he said that his vision has been significantly improved.
Just
So
go back one. I think it's important just to say that when he would have had black to the midline. I say that because if the patient notices the field defect themselves, then it must be quite extreme. He won't notice this at all. He would say he's normal, but you can see that there's the beginnings of a bitemporal hemi even on this. It's subtle now, but we haven't got, unfortunately, the ones from the other hospital, which I'm sure will show a complete black hemicircle. Yeah.
And also, he arrived to Charing Cross like quite late, like it was out of office hour, like overnight. So, and this was quite sudden to do this operation. The outcomes, the headache improved, and the visions, he said he significantly improved. And post-op MRI, we could see that he has a good resections. And then he was discussing the post-op, our pituitary MDT, and the histology shows that he's got gonadotroph adenoma with Ki67 of 1 to 2%, which is also kind of like matching with his history of low testosterone before. And then his post-op cortisol around day 7 is less than 41. So he has been replaced with the prednisolone, and we discharged him with low dose prednisolone. And he will need testosterone replacement in the follow-up clinics.
Okay, anybody about that? Just to say that the histology is what we see in all of the non-functioning pituitary tumors. So the non-functionings all seem to be gonadotroph adenomas that don't secrete. Okay, do you want to carry on?
Sure. So I just want to just a little bit touching on this pituitary apoplexy.
based on the Society of Endocrinology guidelines in 2010. So apoplexy comes from the Greek word called apoplexia, means striking away or suddenly. And we all know that this is a medical and endocrine emergency. And it is caused by the hemorrhage or infarction of the pituitary glands. And then they say that 80% can be just initial presentation of the pituitary adenoma without knowingly that he has previous history of pituitary macroadenoma. 8 to 10% would be having a previous history of pituitary macroadenoma. And then predisposing factors could be systemic hypertension, recent major surgery, or coagulopathies, or any sort of anticoagulants, head trauma, and pregnancy. So the clinical features of pituitary apoplexy, and the first and the most common presentation is headache. It is because of the increase in the intercellular pressure that suddenly increased, and most of the patients are presenting with headache. However, we know that headache is the most common presentations, and it's kind of like a different differentials. We need to find out about different sort of headache. And also patient can present with nausea, vomiting, decreased visual acuity or visual field defect, reduced consciousness, fever, or some patients can give with the meningeal signs. And these are all the non-specific neurological emergency presentations. So especially in the pituitary apoplexy, the clinical presentations, it depends on his anatomical proximity during the tumor expansion. And if the tumor goes upward, and then it can just compress his optic pathway and present with visual field defect, or downward can go to sphenoid sinus, can present with a epistaxis and CSF rhinorrhea. If it is lateral, going to cavernous sinus or cranial nerve 4 and 6, can present with the eye signs like ptosis, eyelid edema, ptosis, pupillary defect, or ophthalmoplegia. And again, like another assessment, important assessment, is also endocrine dysfunction. A majority of the patients, at least 80%, can have one or more anterior pituitary hormone deficiencies at the time of presentations. Especially they have low GH, growth hormone, low ACTH, or thyrotrophin, gonadotropin, and ADH. In our patient, it presents with low gonadotropin plus low ACTH. And clinically, we all know that ACTH deficiency is the most important because of the secondary adrenal insufficiency. And investigations, I think for every of this neurological emergency, the first foremost investigations we would do it with the CT head, and which is also kind of saying that it's insensitive unless there is a big intracranial hemorrhage present, and the pituitary mass may be evident and maybe hyperdense, and you can see in the arrows that showing that here. So in every pituitary apoplexy, it is recommended to have MRI head, MRI pituitary. So it is the most sensitive tool to diagnose pituitary apoplexy and also adenoma and hemorrhagic degeneration. And also this recommended to have the urgent MRI pituitary if the patient is confirmed or suspected pituitary apoplexy. So management, and we also manage with like normal our ABCD, and also hemodynamic stability is utterly important with fluid and electrolytes. And also it is very important for the clinicians to exclude the acute secondary adrenal insufficiency, because 2/3 of the cases of pituitary apoplexy presents with secondary hypoadrenalism. And we have to give prompt corticosteroid replacement if hemodynamically unstable or there are signs of hypoadrenalism without waiting for the cortisol level. And also it is also important to have the neuro-ophthalmic assessment to check visual acuity, visual fields, and ocular paresis. And then if we think that this is like a suspected pituitary apoplexy, we must discuss with the neurosurgical team. And then we have to refer the patient to the neurosurgical center once we discuss and be accepted by the neurosurgical team. So for this patient, surgery or conservative management. It's also very important. And the guidelines say that surgical compression is indicated if number one is deteriorating level of consciousness, and number two is severely reduced visual acuity and visual field defects. And also, they also mentions about like if there is anything like ocular paresis, which is cavernous sinus invasions. I'm not sure, Prof, saying that cavernous sinus invasion is quite difficult, but this is what is in the guidelines in the papers that because of the cranial nerve 3rd, 4th, and 6th involvement. So this is what the this is what the guidelines said. If we suspected of the pituitary hypoplaxy, the first important thing is hemodynamic stability, fluid electrolyte balance, and make sure this patient needs something like hydrocortisone or not. And also, we just need to do all these bloods, including the anterior pituitary functions, and urgent MRI to confirm diagnosis, or if you can have MRIs contraindicated, dedicated CT scan, and we liaise with the neurosurgical endocrine team after the diagnosis is confirmed. So if the patient has severely reduced visual acuity or visual field defects and deteriorating, we go to the surgical management. Or if the patient hasn't got this kind of signs of really like mild visual loss, reduced visual acuity, and we will manage conservatively. However, the conservatively means that it needs a very kind of like close monitoring by the neurosurgical team, endocrine team, and also need daily assessment of his visual fields until patient has improvement, and also needs neuro observations and daily renal functions electrolytes check. And if the patients are found to be stable and improving with the assessment, yes, we will continue treating conservatively. Or if the patient has reduced visual acuity or loss of visual fields, we will consider surgical management. So the outcomes say that the visual acuity and visual field effects and also ophthalmoplegia are reported in most of the cases, either conservative and surgical decompression. But I think a immediate post-operative patients improvement is like more significant and observed immediately. And some continuation of improvement persists after the surgery, like in our patient. And visual recovery, however, the patient has like a monoocular or binocular blindness, I think visual recovery is the less likely. And also the timing of the surgery is also important, how quickly we can turn around the visual fields. Also, endocrine assessment. Majority of the patients need some sort of hormonal replacement after hypoplaxy. And we know that these hormones are the majority of the hormones that needs to be replaced by us. One, like the most important one is corticosteroids, thyroid, desmopressin, any sex hormone steroids, and growth hormone. So long-term monitoring, we need to repeat visual field assessment in post-operative. And this patient, we can see that post-operatively visual field assessment is being improved. And also the guidelines like pituitary hormones to be repeated at 4 to 6 weeks and discussed in the pituitary MDT. And in the long run, we can also consider dynamic testing to make sure that his pituitary functions are recovered or not, like ITT or metarapone and Schwarzenegger test. And MRI pituitary should be repeated in 3 to 6 months post-surgery, then annually for 5 years, followed by every 2 yearly. And also annual clinical review by endocrine and neurosurgical team. So in conclusion, like this is a pituitary hypoplaxy, we all know that this is a medical and endocrine emergency. And the assessment is based on the clinical, endocrine, and imaging. And all these other clinically headache, we need to exclude other causes of neurological complications, and also imaging is important. And also this is like a multidisciplinary team approach whenever we feels like that's not right. That's it. Thank you.
Great, thank you very much. That was a really clear summary. Before you stop sharing, do you want to just go back 3 slides to that that one. So notice, everybody, that the indications for surgical involvement are visual, as in second nerve, not third or fourth or sixth, interesting, like the first patient. So the patient that we talked about earlier, that Lisa spoke about, was managed conservatively, because although she had a complete third, fourth, and sixth, and her eye, she had double vision, she didn't have a visual field defect nor any problem in acuity. And that is the difference, which is surprising to me, I have to say, because a lot of surgeons will have a go, and of course the patient does get better. And there's a lot of discussion about whether or not surgery really makes a difference. I think if you have a real field defect, we're too scared to do a controlled trial. But that's the current guidelines. Notice that this guideline does not say third, fourth, or sixth needing urgent surgery. Any other questions? No questions. There must be some. Anyone want to give any comments? I'll put the QR code for those of you who think you need. You can self-declare, by the way. We're getting a bit more sensible. Let me share my screen. I just got a QR. I've got a QR code here somewhere. There it is. Okay, and it's in the left-hand top corner, but that's all right. Okay, so if you click on that QR code, you can give some feedback. And I'll just leave that there for another few minutes and see if I'll make a recording of this too, for those of you who aren't here. I know you're all here. Any other questions or comments or thoughts from anybody before we go? No, if not, thank you very much. The next diabetes masterclass timetable is up already for the 20th, Wednesday the 20th, and Harriet will. Okay, Vinny's got a question. The difference between Sheehan syndrome and apoplexy, really good question. So in apoplexy, you have a tumor and it doesn't just infarct, there's hemorrhage around it. So that's the difference. Now, Sheehan syndrome is caused by, as you know, postpartum hemorrhage and a fall in blood pressure. And there's no hemorrhage, there's just infarction of the tumor, if there's a tumor there, or infarction of the normal pituitary. And so the patient then presents with hypopituitarism and can't breastfeed. But there's no hemorrhage. Well, in the pituitary, there's hemorrhage in the uterus, but there's no hemorrhage in the pituitary, there's simply a fall in blood pressure. So that is the difference. Whereas in these patients, there's a big tumor to start off the problem, and then hemorrhage makes it suddenly expand and cause that pain that you saw in both of those last 2 cases. They're quite interesting, quite interesting, the difference, because one is infarction and the other has got hemorrhage. There's something in the chat, I think. No, I think that's all. Okay. Any other? I'm going to wait for another minute now that Vinny's put that question up. Thank you for that. And just see if anyone's got any other thoughts or anything to say. No. The outcomes in Sheehan syndrome are lifetime pituitary failure. So you just infarct. So what happens in apoplexy is hemorrhage, and then there might be recovery. Whereas in Sheehan syndrome, the normal pituitary gets bigger and bigger and bigger, and then it outgrows its blood supply when there is a fall in systemic blood pressure. So you have to have a uterine hemorrhage for that to happen. And then you infarct the hypertrophic pituitary. So all the normal corticotrophs, lactotrophs, and thyrotrophs infarct and die, and you then have hypopituitarism. There's lots of questions now. Okay, so I'll start at the bottom. I can see from Nicoletta talking about metyrapone. So metyrapone, I mean, classically, we used to just give them some and wind up the dose until the cortisol was acceptable. And that means between 100 and 300 nanomoles per liter. But over the last few years, we've got a lot more experience with steroids and the use of prednisolone, for example, and my attempt to try and give people a diurnal rhythm. And so for the last few, we've done two options. One is to give 1 gram twice or thrice daily, in fact, at noon, 6 p.m. and midnight. And then you stop. So you have a 6-hour period when they're not on any metyrapine to try and give them a bit of in the morning. Not perfect. We're still trying different doses out. The other is to give a big dose, a gram QDS, and then prednisolone, 3 milligrams as a normal replacement. That has worked quite well for quite a few people. So they're both an option. The starting dose, you start with, each capsule is 250 milligrams. And really, we don't want to do day curves. We want to get them to surgery as soon as possible. But with COVID, everything got slowed down. And so we're doing curves because we're really stuck. The best thing is to operate on the patient. But now we started in day curves. We've been forced to, and it's been quite interesting because we can now see levels, and we're trying to mimic a normal circadian rhythm or give them pred replacement. Let me see some other questions that came up just there too. The PAS score, I'm not sure what that is about really. Do you want to, there's someone here called Valmiki. Do you want to just explain the question? Late breaking query about ivosiledronate. Just want to understand the exact rationale of it on a yearly basis. It's a very good question. Alex, you're there. Alex.
Yes, the question is about...
Can we give zoledronate every 3 years and save money and time?
It looks like it. It does look like it. So the problem is that the original trial gave it every year, so that's what everyone thinks you need to do. We tend to, in the clinic, give it every 1 to 2 years. So you can potentially track bone turnover markers to see when the effect is starting to wane, because those bone turnover markers will start to come up again. But yes, it does look like you can give it less often. It only costs a few quid though, so you're not saving that much, but there are administration costs.
There's a funny fan in your computer making a lot of noise, but we heard that. Thank you. So we'll give it less often. It's not the cost of the drug, which is, as you say, £5. It's the cost of having nurses and infusions and all of us. So if we can give it we need a new guideline, Alex. Is it 3 or 5 yearly? Because 5 yearly would be very cost effective.
Yeah, so there is a study where it's giving it an RCT at the moment, it's giving it every 5 years. So
that will report after I've retired.
Yeah. Okay.
25 years.
But I think the suggestion is that it will last a long time. So you probably only need to give it at least, well, I've shown you the 3 years for fracture risk reduction. So I think we can safely say 3 years based on that. The question is, how long can you give it for without this chronic bone suppression, which increases your risk of atypical femoral fractures and osteonecrosis of the jaw? So there's lots of sort of nuances to it.
So if you give 2 5 yearly doses at 10 years, you'll then have to have a holiday.
Yes, correct. Yes, yeah.
How long will that holiday be? 15-year holiday?
No, if you've had 10 years of bone suppression, you probably...
2 doses, yeah, 2 doses. 1 this year and 1 in 5 years.
And then give it a couple of years at the end well, probably 3 years for a bisphosphonate holiday, and then start again.
Okay.
So 10 plus 3 regime.
Okay, that's quite nice. 10 plus 3. Okay.